Good morning, everybody, and thank you for joining us for the third of our public webinars on COVID-19 and dementia. This time it is on care in all its form during COVID-19. I am Paola Barbarino, the Chief Executive Officer of ARDSI, and with me today there is a panel of extraordinary speakers. This webinar is live and is interactive. We will be asking you questions via poll in a minute, and you are encouraged to raise your questions throughout. We will answer them during the webinar. Please remember that you cannot raise your hand in the raise hand function. You should ask a question through the chat box function. Thank you so much. The webinar is recorded, and a recording and the slides will be available afterwards. Midway through the webinar, we will run an exercise for which you will need a coffee bean or some ground coffee. And now we are going to run the poll. So these are the questions that we are asking you. Can you let us know whether you're a person living with dementia, a family care partner, a researcher, you work or volunteer for an Alzheimer and Dementia Association, you are a long-term care or social care professional, or a health professional, where I can see that many of you work for an Alzheimer and Dementia Association. There's quite a good proportion of researchers and health professionals, and a good number actually of all the other categories. Well, thank you very much. We are now ending the polling. Thank you. Okay, so thank you for letting us know who is on the webinar. I think I have lost you a second. I'm not entirely sure if you can see me. We may be having a technical hitch here. Can you actually see me?
We can hear you, Paola.
Okay, you can't see me, but you can hear me. Good. Thank you. Now I'd like to remind you that we are a charity, and that if you would like to make a donation that will help us continue our work in these difficult circumstances, you would be welcome. If you're watching from a company, please remember that you can help us raise funds through World Alzheimer's Month. If you're interested, please send us an email after the webinar. That's a very important activity. And now a few words about this webinar. Of all the webinars that we have run so far, this will be the toughest one. And that is because behind every word that our speakers are going to say today, there is a lot of people who are not with us anymore. A lot of people who have suffered as a consequence of what happened to them during COVID-19. And what happened to them could have been prevented. It could have been prevented, but it wasn't. And by virtue of not being prevented, this awful occurrence has lifted a lid on one of the biggest problems in our society. And that is, how much do we value the life of those who are our seniors? When I was reading the African report that ARDSI published in 2017, I came across a paper highlighting, in a nutshell, how some African governments felt that they should not provide a safety net for their elderly citizens because once they had gotten old, they were not contributing to society via their labor or via their taxes, and therefore they were not of any use to their government, which should not spend money on them. We could talk about this for the whole webinar, but that statement really shocked me to the core. And then I thought, actually, this is not just happening in Africa. This is happening in a lot of other places too. It's just that we don't talk about it so openly. And now that this crisis has passed and has shown us that that is exactly the case, we understand that the value that we put on the life of the elderly is not as much as we do to the other age groups, period. And our job is not to let the world forget this and work really hard for this lesson to be learned and for this situation to change. So this is what I want to tell you today. And now let's open the floor to my fellow panelists. You can now see that I am joined by a roster of very great panelists. I cannot actually see the slide, but I hope that you can see it. And I would like to introduce you first and foremost to the Vice Chair of Alzheimer's Disease International, a broadcaster and journalist in his own right, Dale Goldhawk. Please, Dale.
Thank you very much, Paola. I discovered new U.S. government information yesterday that shows that so far 26,000 residents in American care homes have died from COVID-19. 26,000 deaths, in fact, represent about 25% of all COVID deaths in the U.S. Now, the numbers in Canada proportionately are much worse. Health officials say 80% of all COVID deaths happened in care homes. Here in Canada, there have been the usual calls for public inquiries, and in years to come, they will report what many have known, at least for the last 20 years, from earlier public inquiries and investigations. No mystery, as far as I'm concerned. It's all about money. Too many privately owned care homes, quite a number are large corporations, must turn a healthy profit for their shareholders and pay executives attractive and competitive bonuses. Care home residents, not really the top priority. Even as a journalist for many years, I have seen and written about the appalling conditions in a lot of care homes. And I have to say the list of deficiencies is almost always the same. Poorly trained staff paid basic minimum salaries, too few staff members trying to care for too many residents. In older homes, 4 residents to a room where infection control is pretty well a myth. Unappetizing food often shoveled into the mouths of residents by staff members simply too busy to take time. In fact, when the Canadian military, yes, the military, was called in to help out in the worst COVID homes, they reported hearing the distressing sound of choking at meal times. The military also reported other usual defects, such as dirty rooms, residents calling for help for hours with no response, the dispensing of expired medication, over-medication of troublesome patients, usually living with dementia, and of course, once again, severe understaffing. I think in a perfect world, all care homes, including the government-run ones, would be subjected to uniform and meaningful standards of care. And if care home corporations can't afford it, they should be encouraged to leave the business and find more profit elsewhere. And governments should be told to increase, not cut budgets that care for the least who need our help the very most. Paola, thank you for the opportunity to speak.
Thank you so much, Dale. This was an important statement and it had to be said. This has to frame our discussion. Today, we will try and present a balanced view, however. We will also have examples of good practice and where good care can actually show us that a situation like this could and should have been prevented and can show us a path for the future. And now I would like to introduce you to Adelina Comas-Herrera. I think we have a slide with a beautiful picture of Adelina, who is the Assistant Professorial Research Fellow for Care Policy and the Evaluation Center at the London School of Economics and Political Science, LSE. Adelina is also the lead researcher on the STRIDE project, of which you have heard before, a very important project that we are running. But in the last few weeks, Adelina has been incredibly busy, having founded the LTC COVID website for long-term care and collecting a lot of important evidence that she has been using as the basis for an interaction with governments around what the shortcoming and failing of the current crisis are. We are all hoping that in future years this will prove a very important resource, a really important point for us to use continuously in the advocacy of government. We should not let anyone forget what happened. Adelina, please, the floor is yours. You need to unmute yourself.
I always forget. Thank you for the invitation. And yeah, I have spent a lot of my career trying to work out ways of improving the lives of people who need care and people who have dementia. And it's the first time in my life where I'm needing to go and understand how to count how many have died. And this has been a huge shock for me and a huge change, I think, for many of us. And I think it's really, really essential that we keep shining a light on what's happening and make sure we can learn from this, as Dale said before. So if you want to go on to the next slide, I'm going to talk about what's happened in care homes and what can be done. First of all, it took quite a long time for us to have any data on what was happening in care homes in relation to COVID, until about mid-April. In fact, until the first country that started to share some data officially were France, and then Belgium right at the end of March, beginning of April. But until then, all we knew was that we had newspaper reports from Italy and Spain and France of terrible situations and lots of deaths. What we found was that in many countries, care homes were not included in the initial responses to COVID. And there was a lot of the focus was on trying to prevent community transmission through lockdown measures, and of course, keeping hospitals safe. That's where most of the resources went. And it was ignored that we had a vulnerable population, vulnerable to the disease, living in care homes, and that they lived in a place where it was very difficult to stop the infection once it entered. And we had some exceptions, though, in some countries in Asia where they had experience of SARS and MERS, and they had learned some tough lessons. Next slide, please. So what we did, and there's the link to the report is here, was to try and find out data from all the countries we could. Up to the 21st of May, we had data of 19 countries. Our very first report only had data from 5 European countries, but it was showing consistently that around half, in the countries where there had been lots of deaths, about half of them had been in care homes. Now we have more countries, we have a bit more information. We know that there are some countries like in Hong Kong, in Jordan, where there have been 0 deaths of care home residents, and then countries like Canada, where the share of all deaths that happened in care homes is now reaching 80%. And we can see these big differences, and this is telling us that these deaths are not inevitable. We move to the next slide. What have we learned? And I'm going to condense a lot of work here in just one slide for the sake of time and to be able to listen to everybody else, is that it's extremely important that we measure what's happening. We have good information on the numbers of deaths in care homes. This will enable us to learn some lessons and work out what we can do in the future. And we also have to make sure that we can show where the big impact is, to make sure that the resources are also going to where the biggest need is in relation to the pandemic. We can't have all the PPE and all the tests going to hospitals or normal care settings where we have so many people at risk and dying in other places. It's also extremely important that we do good work in trying to understand whether the official estimates that we're seeing are missing a very, very large proportion of the population. I'd also like to say that it's important to also consider how many of all care home residents have died in different countries, and this is where Canada maybe is not looking as bad, because in Canada, although we've had lots of deaths, it's about 0.8% of the population of care home residents who've died. But in Belgium, the UK, we're now looking at around 3 to 4%. So there are some countries that have had an even bigger impact if you look at the share of care home residents. And again, I'll emphasize again, there are countries where they've had almost either no deaths at all or very few. These countries have taken very different measures, and we can learn from them. And I'd like to finish by saying that so far, almost all the only information we have about the impact on people who live in care homes is how many died. But of course, there are other impacts and impacts of the lockdown measures we have taken, for example, on people with dementia, of not being able to see their families, being locked in their room without necessarily being able to understand why all this is happening. We haven't really got data on that. We can't really show what the impact is. And this is something we need to know to be able to learn from it. And I'd also like to say that we have actually almost no data at all, except for a little bit in Australia, on what the impact of this has been on people who rely on care in the community and on carers. So thank you very much.
Thank you very much, Adelina. You
I forgot once. I had one more slide. Sorry. So we are very pleased that our work in ARDSI COVID was able to contribute to the WHO Euro guidelines on policy brief on preventing and managing COVID-19 in long-term care homes. And you've got the link here and quite a lot of information about good practices and what can be learned. Thank you.
Thank you very much also for running through it so rapidly. I have a couple of questions for you. But before we get to those, you were extremely instrumental when I first started thinking about this. I remember talking to you about providing me with data from Italy and from Spain. And you did that. That could inform my thinking around why this was a terrible crisis and why were human rights being trampled all over the place. Now, you sent me that data, and this was way before the crisis, for example, happened in the UK or in Canada or in the US. So the data was available weeks before. So what really grates me is that this could have been prevented, because the data was shocking even then, and it wasn't a secret, it was published. Do you think that governments could draw an inspiration from that? Why do you think everybody was so blinkered by this very important fact that half of the deaths happened in hospitals and a good half and more in care homes?
I think we've encountered a combination of ageism and ableism, where all the focus was on what I'd call the normal population. That would be the population who are of sort of middle age of productive, what's considered to be the productive age, and all the effort was put into that. I also think we had lack of expertise in the teams that were set up in most countries to deal with the pandemic to start with. There were no geriatricians, there were no experts on care, and they had completely forgotten to think about what happens to people who may be more vulnerable to this disease. The other factor that is also very important, I think, is that in very few countries we have good data about the health status of care home residents. So when you have a model, if you haven't got information because you've never collected it, because maybe you never thought it was important to do so, it means that all your planning is based on data on people who live in the community. And I really hope that this is something we learn and we can address in the future.
Thanks very much. That's definitely a lesson learned. Another question I have here is whether you think that COVID-19 has caused the shift in governments prioritizing long-term care, and whether you think this is a temporary crisis response or they're finally realizing that they need to support and fund long-term care just as much as they do healthcare more in general.
I sincerely hope that this is the case and that this is not just temporary attention to deal with the bad newspaper headlines. There's a lot of issues that we knew were wrong that we now have a very bright light that has been shown on it. It's been a very dramatic and painful light for so many people. And I really hope as societies that we learn from this and we don't let this go.
Thank you so much, Adelina. We have billions of other questions that we will try and answer after the webinar, or perhaps at the end if we have any time. But I would like to pass to my next speaker, thanking Adelina for her intervention. I would like to introduce Lyn Rogers, who is a person who is living with dementia and who is based in Victoria, Australia, and will give us a testimony of what it has been like to live with dementia during COVID-19. Lyn, thank you so much for joining us. The floor is yours.
Thank you. Sincere thanks to ADI and DAI for this opportunity to speak to you about my personal experiences of living in a nursing home during the COVID pandemic. I have a diagnosis of dementia and live with other complex conditions like most people over the age of 65. I moved to the facility from Queensland, therefore most of my family and friends are not living nearby, and although I use crutches to walk, it's essential I maintain my regular exercise. Whilst it's not my preferred place of residence, I would prefer to live independently in my own home. I felt it was an important decision to make due to living alone and not wanting to place the burden on my family as my dementia or other health issues progress. Since the coronavirus pandemic, I have been denied the right to maintain my regular exercise, which is walking daily in the botanical gardens nearby. I've been doing this for 2 years and wish to maintain this exercise. Even after sending a letter of formal complaint to the owners and board, it took some time for a response, and the letter ended up being sent to the Minister of Health. Once I was granted permission to go walking again, the facility then changed the code on the door, so I was once again locked in. If I'm denied regular exercise, the chance of my mobility being further compromised and me needing to be in a wheelchair will increase significantly. My physiotherapist wrote to the facility recommending I continue to walk in the gardens to support physical health, mobility, mental and emotional health, and general symptoms such as anxiety. My medical doctor agreed, yet I was denied the opportunity to continue my walking and was locked in for weeks. Also of note is that since being denied access to walking, my weight increased in 2 weeks, which is detrimental to my health, and was only due to having been denied exercise as my diet had not changed. I do not believe me walking is risking the other residents or staff, as also note that staff leave the facility daily, thereby placing residents at high risk of COVID-19. I do understand social and physical distancing and always have my mobile phone with me in case of an emergency or need to be contacted. Furthermore, I always wash my hands as per the more stringent requirements since this pandemic and did not intend to sit on public benches. In fact, most cases it's been staff bringing the virus into residents and not the other way round. I also have downloaded the COVID app on my phone to ensure safety for myself and others. The Convention of Rights of Persons with Disabilities adopted in August 2006, in which has been ratified by Australia, clearly states under a number of articles my right to walk. The World Health Organization states that dementia is a major cause of disability and dependence in older persons. It is clear then that I come under the category of a person with disabilities as part from my other complex conditions due to the diagnosis of dementia. The purpose of CRPD is to promote, protect and ensure the full and equal enjoyment of human rights and fundamentally freedoms by all persons with disabilities and to promote respect for their inherent dignity. My human rights and fundamental freedoms are being breached whilst ever I am being denied the right to walk. I am not an object of charity and I do have the right to take risks just like others. My access to walking has now been granted, but being denied the right to walk has caused me significant emotional stress and impacted my health. The need to send a letter to management and to have been denied the right to walk in the first place is a major concern. What of those living in a nursing home who can no longer speak for themselves and who have been denied visitation from their family and advocates? From my own observation of people with more advanced dementia in my home than me, I have observed that they're declining rapidly and don't understand why their visitors are not allowed in or social distancing. Their behaviours and personal signs of distress have increased, choices taken away and fear set in. We are all expected to socially distance in the dining room, but we're squashed in together in the activities room. So confusion once again. No wonder some nursing homes have had outbreaks. These are so many others are concerned we must all be deeply worried about. Thank you very much.
Lyn, thank you so much for this testimony of what happened to you directly during COVID-19. We will be taking questions on Lyn's testimony, and you can please start putting those in the Q&A. Do not raise your hand, put them in the chat, and we'll have some time at the end. Now I would like to introduce somebody who has lived this experience through being a carer. So please join me to welcome Philip Connaugton, who is a carer and a choreographer and dance artist based in Ireland. Philip, thank you very much for joining us for Ireland, and please, the floor is yours.
Hi everybody. So yeah, my name is Philip Connaugton, and I'm the carer of my mother, Madeline Connaugton, who is living with dementia. I've been a carer for her. I've been her full-time carer for the last 6 years at least. And as was mentioned, I'm also a choreographer and dance artist. And because of the intensity of being a full-time carer, that experience has kind of seeped into my work, and my work has seeped into my life. And I've been making work for over 3 years now around the ideas of what it is to be a carer, to be a person living with dementia, but also just physically the ideas of body forgetting and how the body retains information, and bringing that into my world of dance. And also using humor as well a lot in my work, because I think it's quite, generally it's understood to be quite a negative thing. And my mother and I have had a lot of positive experiences in our journey, or in her journey particularly. My mum had to go into full-time care because her situation, our situation deteriorated, and in November she went into full-time care. But you know, there were lots of kind of different packages available, but my brother and I decided to kind of opt for a package opted for a situation where we still had a lot of control over her personal hygiene. So we would visit her every day. We decided that we were going to feed her at least once a day, cut her nails, do her hair, just so we could kind of maintain connection, interaction, and make sure we were really stimulating her in a positive way. On the 9th of March, the care facility that my mum was in closed its doors to visitors. So this was obviously a very stressful situation. My mum's dementia by this stage had developed to a stage where she was not necessarily aware, but from a selfish perspective, it was very, very difficult for my brother and I to kind of deal with this loss of contact. In Ireland, around the 18th of April, the government and the HSE decided to test both workers and residents in care facilities across the board. So my mum's test came back positive, and she was asymptomatic, but this was really, really stressful, not being able to be there, and of course, I imagine that the care facility, because of a lack of workers, there was a skeleton, there was a minimal group of people working there. So even getting answers on the phone to find out how she was very, very stressful. She did actually very well, and although she had been on oxygen for a while, she actually pulled through. And I only realized how stressful it had been when I realized that she was the other side of that. And I think I just kind of collapsed and slept for 24 hours. So there was this kind of holding a massive amount of tension and just trying to be able to deal with that. I was allowed to visit her just once, and I had to, you know, go in, and they put an apron on me and gloves, disinfectant, another pair of gloves, another apron, a mask, a visor. So by the time I got to visit her in her room, she didn't recognize me at all. I mean, and of course there's no facial expression. So it was, although it was wonderful to be there and see how things were going, it was also strangely traumatic because I couldn't touch her and I couldn't hold her. And that's the way it is, I suppose. And I still don't know when I'm going to be able to see her again. I was just allowed in once for those 7 minutes. I suppose the thing that I notice more than anything with this whole situation and the stress of it all is that I kind of feel, I know this sounds strange, but I kind of feel like a parent who's missing out on their child's developmental progression. You know, if you're away from work or something like that, I'm missing out on valuable time with my mother, and I'm missing out on the honor of assisting her on this journey, which I've been trying so hard to do. And that's kind of heartbreaking, really. But let's just hope something changes. Thank you very much.
Philip, I think what you've just shared with us, it's incredible, and it's the reason why we exist, just as much as Lyn told us about the trampling over human rights. is just extraordinary. So thank you for opening your heart to us. There is a lot of support messages that are arriving in the chat line for both you and for Lyn, whom you may want to have a look at. I will now finish with our trio of speakers. Our third speaker comes from working in care, from the care side, and that is Martin Jones, who is the CEO of Home Instead Senior Care in the UK. Home Instead is a company that has been quoted over and over again as an example of excellent practice in care. And we wanted also to have, to give Martin a chance to tell us what are the challenges that even in excellent practice they have been experiencing during COVID-19. Martin, thank you so much for joining us. I know you're amazingly busy. Please, the floor is yours.
Oh, thank you very much for inviting me on this afternoon. I really do appreciate it. And just to give those of you who aren't familiar with Home Instead Senior Care, that we are a global organisation in over 14 countries around the world, delivering over 80 million hours of care in over 1,200 offices. Our founder, Paul Hogan, sits in the World Dementia Council and has done since 2016, I think with Meera, who's later on this afternoon in this call, and Jeff Huber, our global CEO, is on the Board of Governors on the Council on Global Health and Care Industries. And I myself run the UK for Home Instead, and in the UK we've got over 220 offices serving over 14,000 clients. And I play a big role in supporting Alzheimer's Society and others in particular in terms of the Delivering Support Committee. So obviously my business has been the eye of the storm these last few weeks, to try and support our clients live well in their own home, because that's what Home Instead is all about. And those with dementia, to support people with dementia to live well and safely and independent in their own home. I think the unique thing from our perspective is that Home Instead has that continuity of care and that consistent caregiver who comes in and supports the client to enable them to stay in their own home for as long as they possibly can. And the challenges we've been seeing, I mean, I've coined a phrase that the extraordinary now has now become the new ordinary, in the sense of, you know, the situation we're in is going to continue for a considerable amount of time. So I think it's been raised by Lyn and Philip particularly, and I think Dale mentioned it early on, but there's some challenges in terms of PPE, and it's been heartbreaking in the sense of some of our clients that really exhibited the social isolation and how they are being removed from their loved ones, not being able to see their loved ones as much or at all. So we've had to really start to think out the box, and PPE was the first challenge for us. So we've had to think of, because obviously when you mask, as Philip said, you've got a mask on, you've got gloves on, and it can really be a barrier between the caregiver and the client. So what we had to do is really think about what can we do that could help and support that. So some of our caregivers have actually had the names and the faces and what have you, and pictures put on the aprons alongside, so to make it a bit less, more informal, to try and get that emotional bond, because that's what care is all about, and that's why we're, you know, what makes it so special in what we do. And I think the other thing that we've tried to do with the caregiver, so to kind of reduce that social isolation, particularly with the loved ones and the clients and the family members, is use some form of technology wherever possible. And that we've been able to do that with some of our clients in terms of, and that may be through different tablets, it may be through obviously using FaceTime and what have you, and just to that interaction and to help the clients to keep that familiarity with the people that they love. And I think, not forgetting, as Philip was saying just then, in terms of supporting our caregivers as well, we've put an amazing amount of support into our caregivers during these difficult times, because it's been an emotional roller coaster for them as well. And I think from their well-being, it's really important that they are supported not only for training but from a well-being perspective, to give that great support to the clients that were there to help and protect and stay in their own home. And I think it is, I mean, we've talked a lot about care homes today, and I think it is such a shame to have a lot of peers and colleagues in the care home sector that there hasn't been a ring of steel put around the care home, particularly in the UK. And I think it's evident across the world from what we were saying earlier that, you know, there could have been more probably done earlier, and lessons learned from other countries, particularly in how we can support the care homes. And I think that's, you know, this is where home care can also play a part, in the sense of, you know, I think one of my biggest challenges at one time was having 1,400 caregivers isolating themselves at the very start of the crisis. And then that's obviously got better as we've gone through. But I think the most important thing for us is that relationship-based care that Homestead Senior Care offers, and really trying to enable that with the caregiver and the client who, you know, supporting them with dementia, and keeping that contact with the loved ones through that, be technology or very simple things in terms of how we use the pictures on the aprons, etc. That's what we've tried to do. And it's an ever-increasing challenge for us. But I think Philip mentioned it. Sometimes humour and different things like that can go a long way to help and support there. So I think that's what we've done. And also the beauty of being part of a global network, we've been able to share some best practices across. So in terms of certain things that happened in Germany or in Australia, for example, we'll be able to share best practices across our countries and the picture came from another country, for example, into the UK. So that we're blessed that we're part of that network to help and support our clients who are living well with dementia in their own homes. Thank you.
Thank you very much, Martin. This has been a really interesting point. I have here probably too many questions to ask you guys. I want to take a couple though, which I think are interesting. The first one comes from Olivier Constant in Belgium. Olivier is asking, it has taken way too long before structural testing of people in care home was carried out in Belgium, about a month after the lockdown of the care homes. Is this also the experience in other countries? Now, can I ask Lyn, from her own experience, Adelina and Martin in the first instance, to say something about this? Very briefly.
Sorry.
And unmute yourself. Lyn first.
Sorry, can you repeat that? It's gone.
Do you know, was there any testing done in care homes in Australia? Do you know how long was the interval before testing started in residents of care homes?
I don't know that we had testing here because in our area is only a small country area, and there weren't any cases in the community, so we didn't get tested, apart from I had a high temperature at one stage, so yes, I was put into immediate isolation, which was understood, and I had the test, and it took 5 days, I think, before we got the result back. But other than that, we have just all been, you know, kept in the aged care home and not being allowed to go out. So
there was no structural testing, there was no blanket testing, only because you had the symptoms.
No.
Yeah.
Apart from the staff, all the staff had to be tested. They were tested.
Okay, thank you very much, Lyn. Adelina?
So testing is very important when you have high levels of infection in the community, because then you have a very high risk of the infection coming into care homes. I think in a country like Australia, where the levels of infection actually stayed relatively low compared to other countries, the policies would be different in terms of the urgency of testing everybody. And countries like Hong Kong, where they had no infections, they also didn't have to do much testing because they had very low levels of infection in the community. So thinking about Belgium actually has been quite exemplary, even if they acted late, but once they acted, they were extremely open and honest about the situation compared to other countries. They were one of the first countries to publish data, one of the first countries to admit that they had a lot of suspected cases of people who had not been tested. Other countries were much, much more opaque and much less willing to share that information. And they have also now done hundreds of thousands of tests in care homes, and they've published the data every single day of how many tests they've done, how many were positive, how many had symptoms. So Belgium acted late. They obviously have problems in their care home sector that they really need to address. I think longer term this will be very important. But once they understood the situation, they acted very fast. The testing capacity for care homes in the UK is lagging much behind that of Belgium, for example. So we've seen very few countries have prioritized testing in care homes until very recently.
Thanks, Adelina. That was a very comprehensive reply. So I'll ask Martin another question. One of the questions that have come in is about whether there has been in the UK any data about deaths in care home workers. So I'd like to broaden this question for you. I know that amongst the people that you employ to be care workers at home, there's been issues in terms of recruitment because people may have reported in sick or not been able to come to work. So do you want to broaden a little bit that aspect?
Yeah, I think you're quite right. As I said, there has been a challenge for that, and as I said before, in the first few weeks of the crisis, just in the UK, in my own business, we had over 1,400 people self-isolating, and I think that's been quite the case. It's between 15 and 20% in the UK at one time that the workforce was self-isolating. However, there has been, in terms of looking on the upside, if there is an upside on this, in the sense of as this has moved through, there has been other people in the UK actually entered the social care market. So people from leisure, retail, hospitality, etc., who unfortunately have either been furloughed, which is a government scheme, or unfortunately lost their jobs, have actually now started to come into the social care arena. So that has opened the door up to actually for people to join our sector, which is a very rewarding sector. So we'll be able to attract a different type of person we hadn't got before, but it was a real challenge in the early days. And the problem with data is, particularly in the UK, it's so fragmented in terms of the sector itself to get any credible data in terms of carers who would have been isolated at one time would be very, very difficult from a government perspective. And also, you've already pointed out from the care homes, the UK was late in terms of testing, and in terms of, we've really been on catch up, I think, for quite considerable amounts of time now, which is unfortunate.
Thank you very much, Martin. Philip, I am getting tons of expression of support for you. No specific question. I think everybody's been shocked by the experience that you had. I'm really grateful that you shared it with them. I'd like now to move on because we are a bit late on time, and I'd like to introduce you to Saskia Sivananthan, who is the Chief Research and KTE Officer for the Alzheimer Society of Canada, which is a member of ADI. She's the co-lead of the COVID-19 and Dementia Task Force in Canada, which has already done a huge amount of work, and a former senior strategy and policy advisor consulting for the WHO on its dementia strategy. That's how Saskia and I originally met. Saskia, the floor is yours, please.
Thank you, Paola, and thank you very much for the invitation. It's much appreciated. I think it's been very clear, as we've heard from some of the other panelists, Dale and Adelina have pointed out, that Canada has really had a lot of difficulty when it comes to how we've managed COVID-19 in long-term care. And if anything, it's really exposed some significant gaps in dementia care across Canada's broader healthcare system. I do want to point out, though, that really many of the staff in long-term care have been doing their very best to provide the best care that they can under very challenging circumstances, often foregoing seeing their own families to do so. And I don't want to forget that perspective when we do think about what has been going on in long-term care. But really, the rapid spread of COVID-19 in Canada's long-term care homes have really highlighted some major systemic issues that have been there from the very beginning and that have just opened up in terms of the major cracks and risks that we've seen. If we can go to the next slide, please. So I want to start, however, in talking about Canada's policy response to COVID-19, particularly around long-term care. There are some key considerations. The first is that long-term care itself is not included under Canada's Healthcare Act. And this is important because the Healthcare Act in Canada is federal legislation. It's what governs how publicly funded healthcare insurance occurs. So there are specific conditions and criteria that all of the provinces and territories need to meet in order to receive funding federally. And because long-term care falls outside of that act, this means that the programs that are offered across the country vary, and therefore the policies and the responses to COVID-19 have also varied significantly by jurisdictions. If you could move to the next slide, please. So we recognized fairly early that this was going to be a significant concern, that there were going to be some major issues in terms of how we are responding to people living with dementia when it comes to healthcare and long-term care impacted by the pandemic. And so the Alzheimer's Society of Canada convened a rapid response team, is what we call them in terms of the COVID-19 and dementia task force. So it's made up of leading members who are researchers, clinicians, dementia care specialists, but most importantly, also people living with dementia from across the country. And they have a very specific mandate. The task force was convened to identify potential gaps in dementia care that occur across the country, but more importantly, to also develop rapid solutions that could be distributed and disseminated as quickly as possible. And this needed to be done in a coordinated way. So on this slide, you'll see some of the major areas that were identified by the task force. The task force first convened March 25th, and so within just 2 months, we've already identified these areas as well as actively provided solutions. So I'll discuss one, for example, intensive care practices, which we knew would be a potential issue in how people living with dementia might be treated and would have access to life-saving resources. But another one has been long-term care impact. And you could see here a couple of the areas that were included that we are actively working on solutions for: best practices related to end-of-life care for people who are diagnosed with dementia living in long-term care, strategies for human connectedness. We heard from both Philip and Lyn, and we've heard from our own clients as well about how disconnected carers have been from their loved ones who are in long-term care, and vice versa, from those who are in long-term care not understanding or knowing why they're no longer able to see their loved ones. We've also been looking at strategies to support nursing home staff during COVID-19. Another area that has been brought up has been the impact of infection rate. Some of those numbers we still don't know, particularly around clients who've been living with dementia and how it's impacted carers who are living in the community with people living with dementia. Again, an area that was identified as really needing much more data and information, and we're actively working to identify that data and to share it as well as share solutions. If I could move to the next slide, please. The important piece I want to highlight here is that we could not, the task force could not function if it was not through collaborations and partnerships. You're seeing some of the collaborators that we're working here. Many of them are national bodies, and they represent a range of organizations, from national researchers to family physicians, as well as primary, secondary, and tertiary care. And the key here is to bring about an integrated and coordinated response where we can share solutions rapidly across all of these sectors. If we could move to the next slide, please. I want to touch on very quickly what some of the policies are that have been currently implemented in long-term care. As I mentioned earlier, because long-term care falls outside of the Canada Health Act, the policies have been quite varied, and we still don't know the actual impact of them. So you'll see some of the ones that other countries have implemented, for example, restricting all non-essential visits. So this has meant only essential staff. Some provinces have eased and allowed family and friends to be considered essential, but others have not. And so that's meant for several months that family and friends have not been able to go in and see their loved ones in long-term care. We've had a huge issue in terms of shortage of staffing capacity. And this goes back to some of the earlier issues and the systemic issues in long-term care around training for long-term care staff, the fact that many of the long-term care staff don't have sustained employment. And so they will have part-time employment at multiple long-term care homes in order to make ends meet. And so there were temporary emergency orders that were put in place to be able to make sure that you restrict employment of healthcare workers to a single home so that staff are not carrying infection across care homes. We've also had temporary emergency orders where other healthcare staff are being brought in. Dale mentioned, for example, military personnel who are being deployed in some provinces to be able to increase capacity. But they've also been looking at bringing in other volunteers. But of course, this raises other concerns. What about training and appropriate training around dementia care in particular, and around protective personal equipment? How do we deploy these appropriately so that we're still meeting the needs of people who are living with dementia in long-term care? So I'll stop there. And the final comment I'd make is that the focus, unfortunately, in long-term care has been reactive. It's not been on a preventative response. And I think that's been key and been the issue that's highlighted by many other countries, by also the other panelists who've been talking about what we've been facing in terms of the spread of infection in long-term care and the high rates of mortality that we've been seeing.
Saskia, thanks. I mean, your presentation addresses actually a lot of the questions that we have been receiving, especially around the issues of employment, deployment, training of care workers, the massive issues in practice that governments are having to face. Many people are asking, what about these things? And you are telling us that what about them? Indeed, people have had to react very quickly to the situation. And the word reactive is key. People have reacted, they were not prepared. Again, are we going to learn from this? Will we be more prepared? We will increase capacity. Will we make sure that there is some slack in the system when we will have to face this once again, because it will happen. Now, we are not going to stop here for question immediately, although one question came on palliative care. For the person that asked that, we are preparing a webinar explicitly on palliative care in partnership with another range of organizations. So for that in particular, we will address that later this month or in early July. Now, I'd like to introduce you to Wendy Weidner, my wonderful colleague Wendy, who is our research and policy project lead, who will try and wake us up, because we got quite a lot of other things to go, and show us an important exercise. Wendy, the floor is yours.
Thanks, Paola. Well, everyone, this is a quick fire example of an activity that happens often in long-term care facilities and care homes. And this is meant to be reminiscence in 3 minutes. I'm not sure how that's going to go, but all of you have been asked to either get a coffee bean or coffee grounds. And if you do have your coffee bean right now, if you could please put it in your hand and just warm it up while I talk to you for a minute. So what I'm going to talk to you about is our memories and how important our memories are. Each of us, no one has memories like you do. We're unique. Each of our memories is unique. My memories are mine, yours are yours. And they really ground us in our lives. They tell our life story. And they are important to us because they tell the story of our lives. And the scent of different smells often is a very powerful way to evoke memories. I'm often, we'll be walking down the street and you'll catch a whiff of a smell and you'll suddenly be transported immediately back to another place. And you're there and you can feel the feelings you had at that moment. It happens quite spontaneously. And that's why we have the coffee bean. Now, if you've been warming up your coffee bean in your hand, what I'd like you to do is give it a big sniff right now. If you've got coffee grounds, be careful. We don't want any accidents. And have a nice sniff of that. Smell that coffee. Now I want you to think about what that reminds you of. And if you could put your comments in the Q&A box there, just tell me what memories it conjures up. And while you're doing that, I'll give you an example of my memory. Now, when I was a little child, my parents used to take us camping and they would get us up at about 4 o'clock in the morning. and throw us all in the back seat of the car. And they would have coffee in the car. And Laura's going to show you a picture now. They had it in this thing called an air pot. It looked exactly like that. And there was a little lever on top, and they'd pull it back and the noise would come out, and the coffee would just waft. The smell would go throughout the whole car. And I would be drowsy in the back seat, and I would feel excited to be going away and safe with my parents. And this is what that smell reminds me of. So now I'm just going to go to some of your comments and see if you've added some of your memories here. So someone has actually said that a lot of people with dementia have a poor sense of smell, but hopefully you have a very strong coffee bean and you will be able to smell this. I'm trying to see if anybody else has got a memory for me. Oh, here's one. Relaxing at the cottage in the hot tub with a coffee. That looks fantastic. That's from Kathleen. Looking down the hill at the lake. Wonderful. Daisy says, sitting at home early in the morning with my grandma drinking coffee without my mother knowing it. That's brilliant. I like that. Let's have another one. Elaine, I know Elaine from Brazil says, it reminds me of my childhood and me at the age of 7 preparing coffee to my parents who were addicted to coffee. So it's fantastic. I'll stop there, but you can see there are different memories. Mine is associated with going away. It can be sneaking coffee with your grandmother. It can be making coffee for your parents who love coffee. It doesn't really matter if our memories are different because they can be shared. And when we share something as our memories with something as simple as a coffee bean, it brings us together. It helps us communicate, and then we make a connection. And this is especially important to people who are living with dementia. Those connections are so important. There's no right or wrong answer because it's our memories. They're unique to us. And this is so important. It doesn't matter how old you are, how young you are, what color your skin is, where you're from. You can share something with just one object. And when we share our memories, it brings us together and makes us closer together. So I hope that gives you an idea of how reminiscence sessions are run. And back to the show. Thank you, Paola.
Thank you so much, Wendy. I had some really lovely memories by smelling that coffee. So I would like now to move us on to Alison Dawson, who is the Senior Research Fellow of the Faculty of Social Sciences of the University of Stirling, and she's the co-leader at the Faculty Dementia and Aging Research Group. Alison, thank you so much for being with us and talking to us about care home design. Care home design is key. A lot could be done by improving care home design after we have learned so much in this pandemic. Alison, the floor is yours.
Thank you, Paola. I'd like to start by thanking ADI for the opportunity to talk today, but also because I know I'm going to run short of time at the end, I'd like to thank everybody for listening. I really appreciate that. I've only got 5 minutes for this presentation, so I am going to be talking quite quickly. But you can get in touch with me afterwards. My email address is going to be on my first slide, as is the internet address of our Dementia Services Development Centre, where you'll be able to find further information and resources about good care home design. So staying with this slide for the moment, what benefits can environmental design bring to those who are living and working in care homes? Well, firstly, I should be clear that when I talk about environmental design, I don't just mean the buildings, I also mean things like room layouts, interior decoration, fixtures and fittings, the control of lighting levels, of temperature and ventilation, and outside spaces such as gardens. Good design facilitates the interaction of residents with their environments in ways which maximize the physical and psychological well-being and quality of life of that person. I've listed some key benefits on my slide, but the best environmental design works in terms of thinking out how, with the resources that are available, core design principles can be incorporated in any care home, anywhere, to maximize those sorts of benefits. So just to say that the picture on the left-hand side of my first slide illustrates the provision of clearly visible, easily accessible, safe outdoor areas, which are designed to both promote and support residents' use and provide opportunities for interaction. The picture on the right-hand side shows how furniture and furnishings can be used to create a familiar feeling space. The design principle isn't about how the space appears, but how it's experienced by the user. So the geographical context, cultural context, and care context will all determine how that space looks anywhere else in the world, in terms of, for example, styles of furniture and the kinds of materials that are being used. If I could have the next slide, please. So if we're thinking about how different elements of care home design present challenges to minimizing disease transmission or controlling infection, I think we first have to be honest and acknowledge upfront that we don't have an established evidence base to draw on. In the past, there's been very little direct consideration of the impact of environmental design on infection control in care homes specifically. Much of what we know has been gleaned from healthcare environments and not home-like environments, and there are differences. And we're also still learning about the transmission characteristics of the virus itself, and I think that's really important. So we all live with the potential for infection from viruses, for example, such as influenza, and actually care home providers routinely use standard infection control precautions. For example, good hand hygiene and the cleaning and disinfection of commonly used surfaces and shared equipment in order to reduce residents' risk of infection from those. But on top of that, we now need to supplement those by specific transmission-based precautions. So COVID-19, we know it's highly infectious, and we know that it's thought to be transmitted primarily through infected respiratory droplets, which are produced when people with the virus cough, but also through contact with surfaces that are contaminated by such droplets. Care homes in their design create shared spaces, for example, lounges, dining rooms, I think Lyn talked about dining rooms, staff restrooms, all of those places where residents and staff interact in close proximity. And there are risks of droplet transmission in such spaces. But there are risks of contact transmission where surfaces cannot be adequately contaminated. Unfortunately, what we don't really know is how long a virus might survive on the different surfaces that are commonly found in care homes that might be harder to clean thoroughly. So for example, furniture, furnishings, fabrics, those sorts of things. So we don't really know that very well. We know that temperature, relative humidity, and air ventilation rates all affect the time that respiratory droplets can remain in the air. So there is potentially increased risk of disease transmission in parts of care homes which have higher rates of person traffic. So for example, frequently used corridors. Can I have the next slide, please? So in the absence of knowledge, we're obliged to take the safest possible course of action. And that's led in many cases in different parts of the world, and including by the British Geriatric Society here in the UK, to recommend that restricting residents' movement in care homes will help to stop the transmission of infection. However, we have really good evidence that there are a possible range of negative impacts in terms of physical and psychological health if that continues in the longer term. So we don't know when we're going to how long we're going to have to live with the threat of coronavirus, and we urgently need to find solutions which strike an acceptable balance between the risk of infection for residents, but also respecting their rights to be supported and enabled to live their best possible lives. We urgently need research to understand if there are care home design characteristics which are associated with increased or reduced likelihood or severity of disease transmission. And we then need to come together to use that knowledge to develop evidence-based environmental interventions that are capable of being adapted to different international contexts and which can be deployed to enable care homes to both manage the COVID-19 threat, but also to continue to provide the kinds of opportunities for activities and for social interaction which are so important to residents and which support resident and staff well-being. So thank you again for listening.
Thank you very much. This was a great presentation, actually, and I've got one question for you. But before that, because we have a little bit of time, we'll run out of time, attendees, so we'll be a little bit extra, but I think this discussion has been so amazing that you will not begrudge us if we go a little bit away of time. Saskia, there was an interesting question in the chat box, I don't know if you saw it, which I think we should tackle publicly. Somebody was saying whether you had experiences of people being wanting during COVID-19 to take a relative outside of a care home, having heard what the problem was. And in two cases, the question poser is pointing out, in one case, the person wasn't allowed to leave. And in the second case, they couldn't find adequate care to help them at home. Perhaps Martin may want to add something about that with home instead. So Saskia, could you take both parts of the question if you can?
Absolutely, and thank you for that question. It caused quite a bit of concern because as the rise in deaths in long-term care started coming out, those numbers started coming out, and we saw it in the media. There was a call for action by some key media members and a clinician who recommended that you should take a loved one out of long-term care. If you had someone in long-term care, and as you can imagine, we got the Alzheimer's Society got a lot of questions and concerns from caregivers wondering what to do, because you're already dealing with quite a bit of stress and anxiety and other emotions, fear, and now on top of this, what do you do? How do you bring a loved one home? One of the key points for consideration, and it depended by province, but for the vast majority of provinces, is that if you pulled a loved one from long-term care, your position in long-term care is no longer held for you, which means that after the pandemic or at any other point, if you want to bring your loved one back into long-term care, you may no longer have that spot available for them. And we already know about the wait lists and the issues there. There were new policies that were put into place that started allowing you to still hold that spot. Another concern was that, exactly as you highlighted, when you bring this person home, there were other concerns. What are the home care supports? We know, we've heard it directly from our clients and from our frontline staff, that with the pandemic, most of the programs and services that were providing that support in the community were pretty much decimated or are at such high capacities in terms of workload that they can no longer provide the support that you need if you have someone who has multiple chronic conditions and care needs. And so we were receiving huge concerns from carers who could no longer manage at home because you can no longer take your loved one out, you no longer have respite care options, and personal support workers who might have been coming into your home to provide additional care may no longer be available, or you're worried about bringing them into your home because of, again, infection spread. So I'd agree that these were huge concerns. There have now been some answers that have been provided through different forums, including through ours, to help you in weighing out these decisions and where you can go for additional supports, but it continues to be a major concern.
Martin, 15 seconds. Do you want to add anything to that?
No, I mean, just in terms of, I agree with most of what I just said, in the sense that I think it's, with the home care sector being under such strain through this crisis, it would be very difficult to actually to pull those loved ones out of the care homes. So I think, how you do it, when you do it, and what support you'd have, and how you wouldn't risk further infection, would be a big challenge.
Thank you very much. Alison, I've got a brilliant question for you. I really like this from Chloe Shaw. Outdoor / green space activity seems so important for everyone. Actually, Lyn also reminded us of that. At a time when access to the outside is restricted, what design / technology can be used to bring the outside in? Alison, this is one for you, definitely.
Okay, well, I mean, in the short term, we can think about how we can introduce particular plants to the indoor environment that help to bring green inside. We can make the most use of the spaces that we have, which provide views to the outside, even if we can't get outside. We can think about different ways in which we can perhaps reconfigure the space that we have in care homes to enable people to use it in ways which help to reduce the potential for transmission, but also allow people to make the best possible use of the environment that's available to them.
Thank you so much. There's a lot of ideas, isn't it? I personally saw in South Korea some amazing piece of virtual reality. They broke entire forest walks inside a care home. And I'm sure that more use of technology could be adopted more widely, but it's very expensive. So obviously not everybody around the world would be in a position to be able to implement. So the idea of plants, for example, which are more widely available, is such a nice, simpler way of doing that. Skylights as well, of course. Now, I want to move on because we're running out of time, and I want to make sure that Meera Pattabiraman, who's the chair of the Alzheimer and Related Disorder Society of India, a board member of ADI and a member of the World Dementia Council, has a chance also to tell us about the fantastic work that ARDSI has been doing during this time, and give us an example of the difficulties that they have been going through, which is one of the most interesting cases. Meera, the floor is yours. You'll have to unmute yourself if you're speaking. I can't see you right now, but if you are not on unmute, yes, there we go.
Hello, everyone, and thank you, Paula, for the opportunity to talk about the daycare scenario in India under the existing COVID situation. The Alzheimer's and Related Disorder Society of India has been running daycare centers in different parts of India, and these are being run by both the national office and the chapters of ARDSI. The sudden lockdown by the government in order to curtail the spread of the disease has resulted in the fact that we had to close down all our daycare centers. And this has created several challenges, both for persons with dementia attending the centers, as well as for family caregivers. So now I'll briefly touch on the challenges faced by both these categories of persons and the initiatives that ARDSI has taken to counter this. For persons with dementia, they have been used to a certain routine, and suddenly when this routine has been stopped, they have developed symptoms of irritation, confusion, restlessness, boredom, and this has in fact aggravated some of their behavioral and psychological symptoms. And the initiatives that we have taken are to provide support through distance mode, video calls to help them keep engaged with cognitive stimulating activities and other meaningful activities, so as to keep their BPSD symptoms from worsening. And as regards family caregivers, suddenly now they are faced with a situation where they have to provide 24-hour care, and they also have to manage the household chores because many of them have helpers coming in, and suddenly these helpers also have stopped. So consequently, they are stressed out and they are worried about how they will manage every day and what happens if there's an emergency. Going to the hospital or to meet the regular doctors are also difficult, and all this has raised the anxiety of the caregivers. So our care staff have developed rosters so that there is one-to-one counseling provided to the caregivers, and they are also linked to support services like Elders Helpline, emergency services, and an update on the evolving government announcement because they keep changing from day to day. Also, the caregivers are educated on various precautions to be taken like hand washing, social distancing, and isolation. We're also coordinating with our doctors on panel to have refill of medicines, and we're organizing carer support groups via video calls to provide home-based care, and this is proved to be very, very beneficial. Next slide, please. As regards governmental directives for elderly, there is plenty, but there have been no specific government directions with regards to dementia. And the government has issued a health advisory for the elderly. There's also a new app launch. It's called the Arogya Setu app. Arogya means health. Setu means bridge. So it is the bridge to good health. This is available in 12 languages, and it aims to connect essential services to combat this pandemic. Comprehensive guidelines have been issued for persons with disabilities, and helplines for senior citizens have also been set up. And in the state of Kerala, a scheme has been started for providing essentials for the elderly. This has been very useful because the elderly are not able to go out and get things, and this has proved to be a very beneficial scheme for elderly. And this also helps persons with dementia and their caregivers. So next slide, please. So will daycare center come back in India? Most certainly. We are all hopeful that when restrictions are removed, and I'm happy to tell you that in Cochin, which is in Kerala, we just started operating our daycare a few days back because the restrictions in Kerala have been removed. And the centers in Hyderabad and Kolkata, they will also start their functions as soon as the restrictions are removed in those states. One interesting fact that I got from Kolkata is that 40% of the caregivers are willing to wait for another month before they send their family members. 50% will send if they're sure that precautions and protocols are taken. And 10% are no longer able to come back to the center because their health has deteriorated in the past 2 months. So we at ARDSI are trying our best to develop protocols and effective methods to see that persons are taken care of well. We are following all the precautions. And we're also hoping that we can make COVID testing possibly for our clients, family members, and staff. This has been a very contentious issue because most persons are not tested. So we would like, now private testing is possible in India, so we like to start this. And I like to conclude by quoting a couple of persons. One from Hyderabad, she's the daughter-in-law and the primary caregiver, and she said, "Of course, I will send my mother-in-law to the daycare as soon as it resumes, as it is the only social interaction." And another person from Delhi, he's the husband and the primary caregiver, and he says so nicely, "That was my only respite time and support." So in general, the family members have expressed their confidence in us that they will start sending them to our daycare centers when we resume. Thank you.
Thank you so much, Meera. And having seen some of your wonderful facility, I am delighted to see that you are being able to reopen them again. I've got straight off the bat a great question for you. Somebody's asked if you can share an example of how to conduct an activity for people with dementia online.
Oh, something like music therapy, yoga, they all enjoy singing and dancing. So that is what we do. So, the caregiver, they are used to a routine when they were attending the care center. So what they do is online on the video, they play the song, this is their favorite song, and they start dancing, and then you can see the reaction from the person. They enjoy, they sing along and they dance. And then we also have basic exercises. So the person here does it, and we have asked the person to do that. That has been very, very beneficial. Basically to keep them engaged, which otherwise our family members are not able to do. And that's why the boredom sets in. So, but when we do it, they enjoy it, and then that's good for us. So that is what we've been trying to do.
Thank you, Meera. And I should remind everybody that in ARDSI, the first time I saw telemedicine in practice, which was born out of logistical difficulty of getting psychiatrists from one side to the other of the city. And now look where we are with telemedicine, and everybody's talking about it. So it first ARDSI, Meera. A second question for you is, how do you transport people to and from the daycare center during COVID-19? Any tips for that?
Yeah, that's a really good question. Because essentially transport is a difficult issue. Getting persons to the center and back, it has always been a challenge. In most of our centers, the clients are brought by the family members. So they either use their own cars or they use public transport. But right now, because of the lockdown, there is no public transport. And that is one reason why we had to shut down the centers. But the only place where we have our own vehicle is in Cochin. And that's in Kerala. That's where we have started it. And that's because we are taking our vehicle to the homes. And because we went through a bad patch, 2 months, our center was closed. The project officer in charge is now driving the vehicle himself, and he's going to the homes, collecting the persons. The only thing is, because of social distancing, earlier we used to take one shift, but now we have to go twice to collect the persons and then come back. But in other places where they have to bring them on their own, we have to wait until the restrictions are removed and transport is freely available before we start the daycare center.
Thank you so much, Meera. Now we have a little bit of space for one last brilliant question that has come in for Philip. So Philip, if you're on, unmute yourself. It's from Dan Ge, who has asked, Philip, can you share how you manage your own self-care while spending 60 years taking care of your mother? We know how important well-being has been during this COVID-19 period for carers as well. So Philip, that would be really helpful, I'm sure, to a lot of people online. Philip, have you unmuted? We may have lost Philip, unfortunately. So we won't be able to take that question. Then the same person, Dan Ge, asked for another question that was addressed to Meera. Can you share how consent is obtained by caregivers for the counseling support during the lockdown? Meera? Meera, have we lost Meera as well? No, Meera, you got to unmute yourself.
Yes. There is no separate consent. It is just consent to say that they are taken care of well, but we don't have a separate consent for counseling. But we have with their, they've agreed to this because they are really stressed out and they have come to us saying, can you help us? So we are offering them a service which is beyond our scope. Earlier, we were not providing this for the family caregivers. We are only taking care of their persons with their family members. But now, because we know they are stressed out at this point, and they have come to us saying, can you help us out? And we know they're going through a bad time. So we have developed this roster, and it has proved to be very beneficial. But in principle, we have not taken any consent from them. But it's a mutual, like a friendly, service that we are doing for them.
Meera, thank you very much. Now it's time to draw this webinar to a close. In my closing remarks, I have to remind you how important this has been. There's been a lot of questions that really were addressed to me. What are you going to do about this with governments? Well, be aware that all of that is being said and everything that is being shared is going to be used in years to come to remind governments over and over again about how they were unprepared to deal with the rights of senior citizens and how every single one of these lessons is going to be used in the constructions of better models and better care pathways and systems that we will be bringing to the governments. And something that they have to deploy in order for us to present a much better future for people living with dementia and for their families. I thank all of my wonderful panelists. I have counted at least 25 nations online. I am told that there are many, many more. So we will release, as usual, the stats about the webinar very soon. Equally, the webinar link will be posted as soon as possible. So those of you that have not been able to see it online will be able to see it again. Finally, last but not least, I do need to thank my wonderful team, and in particular Wendy Weidner, that has brought us through the coffee exercise. I still have ground coffee all over my hands. And to Annie Bliss, and to Laura Daba, and to Katie Bingham, who are with me on the WhatsApp group that manages the entire Zoom call. I hope that for all of you, this has been another interesting experience, and I hope that you will join us for future one and keep on learning and remembering with us that we need to make sure that we will preserve these memories, these testimonies for when we will tackle our advocacy in years to come. Thank you so much, everybody, and have a lovely day. And yes, of course, remember to make a donation if you can towards ADI. We are a charity and we really appreciate that. Thank you so much. Bye.